Hi, everyone. I'm Amelia Delphonse. I am the co-owner of Master ABA. I co-founded Master ABA with my twin sister, Diana Kelly. I am here today with Nikki Dione, who is going to talk to us about neurodiversity affirming ABA practices. And I'm really excited to hear what she has to say.
Thanks, Amy. So as Amy said, my name is Nicole Dione. I go by Nikki. And we are going to talk a little bit about neurodiversity affirming ABA today. One thing that I like to do before I go too far into trainings is just tell you a little bit about myself and why I train on the topics that I train. Briefly, I have been a licensed clinical mental health counselor in the state of New Hampshire for approximately 19 years. And for the last almost 2 years, I've been a board certified behavior analyst. The majority of my career has been supporting individuals aged 0 to 25. And in the last 6 months or so, I have expanded my practice to work with individuals of all ages. I was diagnosed in my early 20s with ADHD and have spent a lot of time since then kind of realigning my understanding of myself and how I interact in the world, how the world interacts with me, and kind of, trying to maybe heal and understand some of the experiences that I had as a young child. Um, because I did contact the environment a little bit differently. And because of that, I think I have a really large passion supporting individuals who are somewhere on the neurodivergent kind of arena and community. I think I have some lived experience. I also, feel like it's helpful to come from an understanding perspective. So because of that, I spend a lot of time doing trainings around the type of care that we provide to the individuals that we are supporting. I focus primarily on autism, but you'll hear me through this training also talking about possibly other people who are within the neurodivergent community. So the training today is split into two separate lessons. The first lesson is really focusing on understanding neurodiversity affirming care. We'll talk a little bit about the neurodiversity movement, talk about some research in ABA. And then the second lesson will be focused on action steps that we can take to integrate neurodiversity affirming care into our own practice. At the end of each lesson, there will be a quiz. And once you take the quiz, you can move forward to the next portion of the training. I'll review this again at the end, but CUs and evaluations and everything will be available after the training is complete. If you have any technical issues during this training, please feel free to email support@masteraba.com and they will help you figure it out. I appreciate their tech savviness because that is not me. So I always like to kind of start, each lesson or just kind of throughout our trainings, talking a little bit about some personal experience that I have had. And also kind of looking at some of the people that I've supported over the years and how some of their experiences and information kind of drive my passion and desire to help train, people in the field to be as aware and supported and compassionate as we can be for the clients that we are working with. So I like to start kind of working with, in the last few months, with a later in life diagnosed autistic adult person who came to me for therapy, mental health therapy, who had experienced a very long history of multiple providers, multiple services, and expressed a lot of challenges that they had experienced in their life. And one thing that really had stood out for me for this individual was that they were coming here worried that they were about to lose their sixth job, and really kind of seeking out, in our intake and identifying, I just want to know what's wrong with me. Like, what's wrong with me that I keep losing all of these jobs? We found out over time that this individual met criteria for an autism diagnosis. And we have started kind of working on realigning what that means in their life. And, we've talked a lot about some of the harm and risk that she has experienced over her life due to not understanding why she contacts the environment, in a slightly different way than her siblings and the peers that she grew up with, and has really started to identify a lot of struggles and how this, has informed her own identity. So this person is very lucky and works at a place now that is more supportive than other employment, places, and have been willing to talk with myself and with this individual to provide accommodations and understand kind of what their experience is. But really thinking about, how this individual came in with contact probably with a minimum of 10 different providers over the years, and how, their experience is that the system really has failed them. That if they had an understanding of, their brain and what it's like to be autistic, and understanding, how that might impact some of their day-to-day functioning, really feeling that they would be in a different place. And so we, as providers, as BCBAs, as people who work in the field of ABA, have a responsibility to make sure that the services that we're providing to our clients is informed and affirming to who they are as people. And I just wanted to start kind of with that story as we go into this first lesson, just to provide some context about, you know, what what is important in the information that we gather and how we understand the people that we're working with. So I'm going to just start out with some statistics and talk a little bit about diagnosis. I always cautious talking about these things in a neurodiversity affirming care training because the information and the language that's used in a lot of resources is very deficit based. And we'll talk a little bit about medical model in a few minutes, but I think it's just helpful to understand kind of where we're coming from. So the new statistics, according to the Center for Disease Control, in regard to people who meet criteria for an autism diagnosis, and I'm going to talk about language in a couple minutes. So I'm reading these directly from the CDC website. The new statistics identify that 1 in 36 children have been identified to meet criteria for an autism diagnosis. Autistic individuals are parts of all communities, so there's no difference between racial, ethnic, or socioeconomic groups. Autism is 4 times more common in boys than girls. I apologize, that is a typo. 1 in 6 children, so 17% of children between the ages of 3 and 17 years old were diagnosed with a developmental diagnosis. And within that includes autism. And ADHD is prevalent in 5.9% of children. Autism is 2 to 4%. And oftentimes we find that autism and ADHD are co-occurring. And I'm not going to get too far into the mental health diagnosis world because I really don't want to live in a medical model for this training, or, kind of live in a diagnostic place for this training. But it is important to understand that individuals who are included in these statistics most likely have co-occurring diagnoses. As individuals are older, autistic individuals have a higher likelihood of also being diagnosed with anxiety and other diagnoses, especially if the diagnoses and services that are received when they are younger are not accurate. So those are just some important things to think about. So interesting kind of as I've gotten older where my joy of work kind of lives. And right now, I work a lot with early intervention and parents for individuals under the age of 6, but I've started working a lot with individuals who fall into the category of being autistic and receiving a late diagnosis of autism. And, these are kind of communities that are slowly developing. A lot of the individuals that I work with are individuals who were born in like the 60s, 70s, or 80s, when information about neurodevelopmental diagnoses and information about how the brain works wasn't as accurate as it is today. And so we have a lot of individuals that I'm seeing, at least in my practice, who come in for therapy services because they are receiving a later diagnosis of autism and kind of thinking back on their life. And again, like I said earlier, redefining what it means to be an autistic individual. I think it's important for me to say here, you'll hear me going back and forth between individual diagnosed with autism and autistic person. We'll talk about language, and I just want to be clear that the neurodiversity movement and people who really are well educated in affirming care prefer identity first language, which is a big shift from a lot of the medical model for mental health, where we talk about person first language. I go back and forth because I work with a lot of people who do not prefer identity first language. I try to be really thoughtful, and I am always learning as I go forth as well. So I am making a constant effort to be aware of my own language and shifting my own language. But by and far, the neurodiversity advocates really push for the community identity first language. So you'll hear me say autistics or autistic individual often. This is my last slide on diagnoses, but just kind of really thinking about how many people who grew up in these decades, so between the 60s and the 80s, and probably even the early 90s, are now just discovering who they are as autistic individuals. They are now, for the first time, really understanding what their interactions with their communities look like, and identifying why environments are not. I have to redo the slide. I'm sorry. I don't like what I'm saying.
Okay,
I'm on the struggle bus today.
no problem.
This is my test because you've had to do like so much editing. No editing before, and now I'm going to make you do all the editing.
I don't mind.
Should I redo this slide too? I'm worried I'm like so in my brain, like I'm worried I'm saying too much language that I don't want to say.
I think it's fine. I think it was fine. I think the things that you're saying are meaningful.
Okay.
So, and accurate.
Typo. Okay.
If that bothers you, change it and go back and redo the slide.
No, it's okay. I already identified it was a typo. Is that okay?
It's totally fine.
Okay.
I didn't catch it either, so.
So the last kind of diagnostic related slide that I will talk about, even though I will continue probably to talk about late diagnosis, is this one. So we're really thinking about individuals who are receiving what's considered a late diagnosis of autism according to the medical model. So individuals who grew up in the 60s, 70s, 80s, and probably even the early 90s, where we didn't have a lot of information about developmental diagnoses, neurodevelopmental diagnoses, are probably, now in their later life, accessing testing if that's what they're looking for, accessing services to talk about diagnoses, talking with people to understand, some of the challenges that they've experienced throughout their life. And many people are now receiving a diagnosis of autism and just accessing the autistic community, and really learning about who they are. So I think it's just important and helpful to understand too some of the identified like gender differences in how we talk about autism and how autistic individuals like identify. So one organization that I really like to look at is the Organization for Autism Research. Some of their older information is not as neurodiversity affirming, but a lot of the new information and how they're sharing information really has shifted, which is lovely when you see these larger organizations really listening to the community that they're doing research for and about. So the historical and current diagnoses show over time that the ratios between males and females are from 3 to 1 to 16 to 1, which is a huge span. So that's, 16 male individuals being diagnosed with autism compared to females. Overall, there's a higher prevalence of white males receiving a diagnosis of autism. Some of the information behind both of these is access to care, service providers understanding how people can present differently based off of their own experience and how their brain functions, and also kind of looking at disparities between socioeconomic status, race, ethnicity, and how people can access or trust care providers. Women are the most likely group to receive what's considered a late in life diagnosis compared to males. So they are, I forget what the average age is, but it is far into like their 30s on average, where males are more likely to receive a diagnosis in childhood, adolescence. And one of the reasons that is identified and really talking to individuals in the autistic community is that women are identified to mask or engage in what they call camouflaging 3 to 4 times more often than men. And so what that means is that while both, men and women, and we're talking about biological kind of gender at this point, but while both men and women will present and experience differences, fixed interests, may engage in some perseverative thinking, may struggle with reading social cues and engaging in communities, women are more likely to be able to mask their challenges and engage in social context. And, kind of thinking about old information and old language, boys, when they're younger, are identified to tend to misbehave, which all this language is medical model. So this is why I'm doing it now, and I'm going to get it out of the way. And I probably, need to do some education and learning on how to shift some of this language to be able to present it in a more affirming way. But really understanding that as providers, it's important for us to understand that when we're talking about autistic individuals, we're really talking about individuals who are autistic, not autism as a diagnosis. And I think that will allow us to kind of meet people where they're at and really provide some good client-centered care. So we want to start there. We're going to kind of move on to really talking about neurodiversity advocacy and the movement. I have some terms that I just like to go over because I recognize, even as I was reading and doing research for this training, I learned something new. So for example, I've always kind of lived in a place where I will talk about neurodiverse and then neurotypical, right? Because that's what's in the language. And I don't have lived experience as an autistic individual, even though I'm diagnosed with ADHD. Our experiences are vastly different. And I'm an individual person who has my own life and history, right? So I read and I go to, trainings, and I, try to follow organizations that are, in the advocacy world. And I've used the word neurotypical. A lot of information out of neurodiversity advocacy looks at neuromajority. So we're not talking about typical and atypical, right? That's a very medical kind of term. We're not talking about normal and kind of abnormal. We're talking about neurodiverse individuals being a minority group within a majority. And I really, for me anyway, that really, kind of clicked in my brain that we're looking at culture, we're looking at communities, right? So, and a lot of the new research is showing that individuals who are in the neurodiversity community experience challenges, experience society in some parallel ways to communities who experience discrimination. And so I just, I will just own that I am still learning and I am human and I make mistakes. And I think that one of the best things that we can do is to acknowledge the mistakes that we're making, listen to the communities that we are supporting and talking about, and then shift our behavior. So for today, we're going to try and use neuromajority because that is the new term that I have learned. So just really quickly, when we're talking about neurodiversity, this is what we're using to describe the many ways that kind of human brains process information. So we have diverse brains, diverse minds, diverse bodies, and we're really looking at neurodiversity is, for context today, we're primarily talking about the autistic community. And so sometimes you hear the term neurodivergent or neurodivergence, and there is some movement, my understanding is, away from that term. So if you hear it, we're really talking about how individuals may contact the environment in ways that the neuromajority does not. So for today, neuromajority is really talking about individuals whose behaviors and ways of engaging in their environment are kind of deemed socially acceptable. So I don't really love the term like socially acceptable, but we're talking about kind of living in different cultures and communities where we have expectations of, behavior. And so when we're talking about neuromajority, it's really kind of the majority who's determining what is like socially okay, which is oftentimes when I work in treatment, really highlighted by some of the conversations I have with autistic individuals who just process information differently or engage in their communities differently and are seen to be engaging in behaviors that are not okay based off of kind of the social majority. And part of the advocacy movement, which we'll talk about in a minute, is really looking at how do we shift the social like majority to be more accepting and understanding in regard to all people who live in, our communities and things like that. So neurodiversity advocacy, I really do encourage anybody who is working with neurodiverse populations to really start connecting with advocates within the community. I think that we cannot speak for people. And I think part of our, challenge if we are in the neuromajority is sometimes we do that. And the information that we have is based off of our own experience and our understanding of the neuromajority. So if you take anything from this training, and like I said, we'll talk about ways to integrate affirming care in a little bit, but I would really encourage you to connect with organizations that are supported by the neuro diverse community. Some of the organizations, which I won't get into here, but that, historically I may have accessed are not in like organizations that are supported by the autistic community. So the neurodiversity movement is a social, political, and human rights movement that is led by autistic, neurodivergent, and other disabled individuals, with the end goal being acceptance. So we're really talking about a cultural movement. We're talking about social justice when we're talking about neurodiversity advocacy. It started in the 1990s with the access or like more global access of the internet. So we had individuals who were able to start to connect through all of the availability. I think back to the 90s and I'm like, what was I using? I was like using AOL chat. Anyone remember ICQ? Like, like literally the letters ICQ. So we had these like chat rooms. We had access to information. We could connect with people on the internet. It was a lovely time. I'm totally like, aging myself here. But what it did is it opened the doors for people across the country and the world to start to connect with other individuals that experienced similar life events that they were experiencing. And so the 90s became this really kind of cool, groundbreaking place with the, inception of the internet for people to start really talking about, wait a minute, we have these experiences. We are not experiencing things in the same way as the neuromajority, and really starting to connect and advocate for individuals to have social acceptance. So the, kind of important part to understand is it is a cultural movement. but it's led by neurodivergent individuals. It is not led by allies. It's not led by providers, right? Which is why I really encourage people to connect with some of the, advocacy or neurodivergent advocacy supported, groups and organizations, because I think it's really important to listen to the people who are telling us what they need, instead of us determining what somebody might need. And so we're speaking with versus speaking for or over autistic individuals, right? So we are, all of the information that's in this training today is information that, and I, try to do as good of a job as I can, that, aligns with what the neurodiversity advocacy community is talking about. But I'm not, speaking for anyone, hopefully my goal is always to walk aside somebody and follow their lead. And I think that that's something that's really important for us to pay attention to. The neurodiversity movement has, addressed all areas, right? So we're talking as BCBAs in the field of ABA for today, but there's a lot of information too, and kind of the speech and language world, the mental health world, the education world, right? Because people don't live in one place. We kind of connect with multiple things in our environment every day, and so it's really looking at how our daily environment can be more accepting of neurodivergent individuals. So I think, as we kind of think about some of these things, it also is important to recognize that when we talk about advocacy, social justice, cultural movements, we're also talking about, as providers, recognizing and understanding our own ethical obligation within our practice, right? And our own kind of presentation of information and how we support the individuals that we're working with. And so I'll talk a little bit about ethics in a few minutes. The other piece to be aware of is that part of our obligation as BCBAs is to access current literature, to be aware of current research, and research and information is catching up, but is not to the place where autistic individuals are identifying what their needs are. So we have to use kind of our critical and deductive thinking and access information that supports the research, because we are practicing evidence-based practices, and we need to make sure that we're doing this in a way that is affirming to the individuals that we're working with. So just understanding that the research and our behavior analytic literature is catching up. And actually, out of all the trainings I've done so far with Amy, I found more peer-reviewed articles about the neurodiversity affirming care than I have for any of the other ones I've done. So that was lovely. There's some really good information and articles out there published in 2023 and beginning part of this year, 2024. Going back a little bit further, you can see where there's still a disconnect in some of the language that's used in research, according to me. So I just encourage you to kind of, look into those things and just be aware of that. Okay. So let's talk a little bit about ABA. I'm hoping that I'm not going to spend too much time on this slide. I am a talker, if you hadn't figured that out already, but my assumption is we are all working somewhere in the field of ABA if we are accessing this training. But I do think it's important to recognize that while I'm focusing primarily on the autistic population and the neuro kind of diverse population, which does include people who are diagnosed with ADHD, dyslexia, dyspraxia, anxiety, depression, we start to think about how brains connect with the world, that ABA as an evidence-based treatment is evidence-based to support autistic individuals. However, we also are working with individuals who are, neurodiverse in general, and we're working with multiple populations. So I think it's important to recognize that this information can be used in regard to how we practice as BCBAs, not how we practice as BCBAs with autistic individuals. So I think it's just important to really think about that. The reason that I kind of wanted to talk about this a little bit is that due to history, ABA has been classified as a treatment. And so when we start talking about treatment, when you hear words like diagnosed with, treatment, we're really starting to talk about the medical model of intervention. And again, I know I keep like dropping this medical model world. I promise I'm going to get there. But when we think about medical model, the first thing I jump to is if I'm providing treatment as a BCBA, that means I'm working with insurance companies. And when I'm working with insurance companies, there are specific criteria that insurance companies are looking for in order to like provide coverage for services. So if you think about accessing, prior authorizations, if you've had to do that, or writing treatment plans or submitting to insurance companies, a lot of our information is deficit based. We're looking to get approved to continue services because the individuals we're supporting with have needs that we believe that we can provide support for. But our language is, Nikki is not doing this, right? Or we're only at this much percent. We have all of this to go. Like we're really thinking about kind of deficit based language. What's happened with that is there has been this kind of historical belief, and I think it's kind of split now. It's hopefully, kind of moving forward and changing, but that there is some harm language in working with insurance companies. Now, I understand we need to be paid. Families have insurance. If they can use it, that's great because services can be really expensive. And, also understanding that when we're interacting with insurance companies, when we're looking for approval for treatment, we have to be cautious that the language that we're using is not working to eliminate autism. And there's a lot of information around criticism for ABA, that harm has been attributed to ABA interventions because of this historical, connection with the service, either trying to cure autism, to normalize, right, behavior. So I was reading something from an autistic individual, was talking really about attempting to have autistic individuals be non-distinguishable from their neuromajority peers, right? And I think back and I definitely have written goals that are using that language, right? That I'm looking to have people be able to engage in their environment the same way that their typical or neuromajority peers do. And there becomes a disconnect. So if I'm not allowed to be who I am as an autistic individual, you're telling me that what is a part of me is not okay, and I have to look like everybody else. We start to look at increase in harm. And a lot of the criticism applied to that is because of the experiences that autistic individuals had, where they felt like they were working to or have to erase a part of who they are. Now, granted, I read some stuff. I am trying to read as much as I can. So, but a lot of the criticisms around ABA really do have to center around with kind of those 3 bullet points that are on the slide. There is, this is from, it's a Neiman article, 2021. All the references will be included in the course. And so, Neiman talked a lot about kind of the criticisms around ABA and how we can understand and be supportive of people's experience. Our job also is as behavior analysts to, we know that there is a lot of efficacy with ABA services, right? So how do we take what we know and how we provide services and also kind of integrate what people are telling us, right, to reduce harm and to provide client-centered care? To kind of continue talking a little bit about the concerns of ABA, a lot of the peer-reviewed literature now is kind of looking at what some of the criticisms might be from the autistic community and autistic advocacy, and then also looking at like how we as behavior analysts can be aware and make sure that we are shifting our practice moving forward to address what the concerns might be. And I was talking to one of my autistic clients, and they are, were diagnosed with autism early in life, but are now an adult, and they are in therapy to process their traumatic experience in ABA. And they did, they identified, it's like there's 2 schools of ABA. There's like old school ABA, which this person was involved in when they were young. And then there's like new school ABA, right? And I won't go all into it because I want to protect privacy and stuff, but it was just kind of an interesting concept of, like every field of science, if you look into history of how the science started, human rights, treatment of individuals that were supported weren't always kind of taken into account. And then we shift into we learn, right? We learn, ethics kind of develop, we learn these new ways. Now, when we think about the field of like medicine, for example, or psychology, we're thinking psychology back late 1800s, right? Early 1900s. The span between the development of the field and now is very, very large. So the people who were engaged in psychology practices are most likely no longer alive when it first, started, and we've learned a lot since then. ABA is a very new field, right? So compared to other scientific fields. So when we start to think about it, we are now working with adult individuals who were, really engaged in early ABA. And as a BCBA, I can say reading some of the early literature makes me uncomfortable, right? And reading the newer kind of evidence-based research makes me feel a little bit better, right? So I can sit back as a non-autistic individual and say, yeah, I get it, right? I can see where our early science maybe wasn't taking into account the human experience. So I just like to kind of say that because that's a lot of language that I will use when people bring up their past experience with ABA. And then part of my job is to inform them if they're interested in learning, right? So that's their choice, about kind of how the field has changed to take into account some of the new information that we have now. So these are just a couple bullet points. I didn't want to spend a ton of time talking about too much of the criticisms because I think that it's good to have the understanding. I encourage you to do some research again in the advocacy community. I really want to, make sure that we're talking about things that we can be aware of for ourselves now. One of the kind of overwhelming things that I found in at least the literature is, the Lovas UCLA Young Autism Project. And I encourage you to kind of read up on it. So when this project first, came out in I don't even remember the years. I should have written that down. I should know this because why don't I know this? But when it first, was in its inception in early programming, even the literature shows that sometimes the use of shock was used, right? There was restraint. There was a rigid application of the intervention. So we stuck with, if we're doing discrete trial teaching, we are doing DTT, right? If we are having this behavioral intervention set up, we're doing it this way. The thing about the UCLA program is over time, there's been really great outcomes. People have made improvements. Their behaviors have been eliminated or improved. And, talking to individuals now who may have been in that, I have that program or programs, like it, do report, some traumatic exposure because of the punishment procedures that were used. If you look at the, kind of outline of the program now, it's, it's just kind of shifted with science, right? So things are more reinforcement based. We are looking at, more naturalistic teaching. We're kind of looking at these things that have come out over time, but we have a lot of individuals who are in the advocacy community who've experienced programs and interventions that, felt very harmful. And so kind of living in this place. And I remember being in school and reading a lot of, articles of, especially about this program of this is great. And then other people being like, well, here's why it's not. And kind of going back and forth and back and forth. And, I think it's just important stepping outside of what we as BCBAs say. What is the advocacy community saying? What are autistic individuals saying? And a lot of individuals are saying that, these types of programs when they were younger has created harm. And I think that we need to be aware of that. And I think we need to understand that that was our autistic clients, experience, and how do we connect with our clients and support them and validate that as we're providing services to them, later in life. And what I've been seeing lately too is that I have autistic parents who were engaged in ABA services when they were young, who now have children and are seeking out services. And some of them have autistic children. Other, families have children who are, neurodivergent and being very opposed to ABA service because of their experience as a child. And so you're starting to kind of see this loop that happens in science, right? But we're in the middle of it now. And so how do we as BCBAs really kind of account for that? So I think it's important when we start talking about listening to any advocacy community, right? So advocacy communities usually begin because there is discrimination of that community from the neuromajority. That's usually kind of where advocacy comes out. And across kind of all advocacy communities, there's two things that really gets talked about. And the first one is ableism, and the second one is implicit bias. I think it's, I always live in this place of myself, struggling with making sure that I express this information appropriately and compassionately, because I recognize my own process with identifying my own behaviors that are ableist and my own implicit bias. And I think that it's important for us to understand that we, across kind of, individuals, are likely to engage in behaviors based off of our experience and learning and all of these things. So we're going to talk about what ableism is and what it looks like. We're going to talk about implicit bias. And then in the second lesson, we're going to talk a little bit about how we can just be aware of these things. So, and I find too, sometimes when we have a hard time operationally defining things in ABA, it's hard to find it in the literature. So again, there's some really good articles that are in the resources or the reference section about ableism, implicit bias, and racism in ABA. And I really do encourage you to read them. And ableism is one of those terms that we have struggled to operationally define. So the kind of global definition of ableism is that it is a type of discrimination in which able-bodied individuals are viewed as normal and superior to those with disability, resulting in prejudice towards the latter. And we're really looking at, we're talking about discrimination against people with physical, intellectual, or psychiatric disabilities. And this kind of belief that these individuals need to be fixed. So I'm putting that in quotes. And if you want to learn more about ableism kind of globally, the Center for Disability Rights has a lot of resources about what it looks like, and, kind of resources of how we learn how some of our behaviors may look or be ableist. And then, we're kind of looking at, so again, we're talking about the social majority, right? So when the social majority has a belief system about the, kind of, in this case, neurominority, we engage in behaviors that support our belief system, but can be discriminating towards the neurominority. When we are thinking about behaviors associated with this, I think it's important for us to look at two things. There's our private behavior. So there are our belief systems, how we, think about things, what we feel about situations. But what are our observable behaviors that we can measure? And so what behaviors are associated with ableism? So Matsuda et al. Talked about some examples of ableism in behavior analytic kind of application. And some of the things that they talked about are, targeting goals for our clients based off of the caregiver's behavior or the caregiver's needs. And I kind of when I talk about these things, like to share my own experience, because I feel like it's important for me anyway to identify that I have a certain upbringing and experience and privilege that leads me to have certain interactions and beliefs in the community and the environments that I engage in. Um, and if, I think the first step is just important to have kind of an open mind. So just to hear the information and start to assess if these are things that could be happening in, kind of our daily service functioning and even kind of general life functioning. So I know that I have sat and developed treatment goals and talked about services with my autistic clients who are young, and have talked to the parents about what their goals are, and not assessed with my autistic client what they might like out of their services. And I at the time did not realize that this could be falling kind of into an ableist mindset or ableist behaviors. Again, now as I've gotten older and done a lot of reading and interacted with communities, I can recognize that my perception is that my autistic client can't know what they want, right? We all know what's better, or maybe because they can't vocally communicate to me what they want, I assume that they don't have preference, right? And so then I work in this, you're the caregiver, you have, you know what's going on. Let's talk about the client versus with our clients. Matsuda also identified, kind of what our perception of typical or neuromajority functioning might look like, as opposed to our clients' quality of life. So I, in the past few years, I worked with a supervisor at one point who talked a lot about eliminating vocalizations and stereotypies. And when I was like I was like, yeah, okay, we'll do that, right? Like, it's disruptive to their life, right? Now that I have talked a lot with my autistic clients and really kind of informed myself on, what is the behavior telling us, it's never a goal of mine unless the client wants to decrease their vocalizations or their stereotypies. I recognize that there is a reason that they are engaging in the behavior. I've had autistic clients who are vocal be able to tell me that when their body feels dysregulated, that's how they cope. Now, I fidget. You can't see my hands. I got a fidget spinner on my desk. I have a little fidget thing. I wear a ring. I have never in my adult life been told to stop fidgeting, but I fidget when I'm nervous. I fidget when I've sat for too long because it helps me soothe my dysregulation. So that is an example of an ableist kind of perspective, right? So really being aware of the language and how we're approaching behaviors, and understanding that elimination of something, especially without a replacement behavior, right, is not valuing kind of our clients' needs, and could be because we are engaging in what we have been taught our whole lives around like the neuromajority and socially acceptable behaviors. And then the last one that he talked about was, kind of thinking about, I think I mentioned it, quality of life. So, and I might bring this example up later. I always get ahead of myself, but I have an autistic individual that I see that's an adult. And they said a few weeks ago, they were having some, kind of peer related challenges. And they said, well, I know that I should learn how to be polite to people. And so we should probably work on that. And when I asked them why, they said, well, because that's what you have to do. That's what you have to do to be successful and navigate. And I said, is that something that you want to work on, or you feel like you need to work on because of what people are telling you? And they said, well, I don't really care to say hi to people that they don't know, right? So this is like walking down the street and saying hi to people. And I said, well, then we don't need to work on that because it causes you stress and distress. And, I'm just like thinking and talking, and the client I was working like literally broke down in tears and was like, that is the first time that somebody has ever told me that I don't have to do something that makes me uncomfortable. Right. And so think about, if I'm working on that goal, what her like quality of life looks like in regard to her social interactions and leaving their house, because now they're engaging in something. They're not rude, but why do we have to say hi to strangers on the street, right? Like kind of thinking about what those look like. So again, just kind of like to connect some of the real life stuff. I, even with all of my reading and understanding and research, because I am not part of the autistic community, I engage in ableist behaviors. And my job as a BCBA is to be able to identify when I engage in those ableist behaviors and then shift my behavior to be supportive and affirming of the clients that I'm working with. And I think that that's just something that's, kind of important to recognize. So one good question, and this comes from neurodivergent advocacy kind of groups, is thinking, does an intervention seek to modify a given trait because it's autistic? Or does it proceed more moderately, only targeting that which is intrinsically harmful? And I kind of really liked that, right? So like, am I targeting something because it's intrinsically considered an autistic trait? Or am I really kind of considering the needs of my client? And if there's a harm situation, we're going to respond to harm. But otherwise, am I looking at kind of the goals and things that I'm setting with the individuals I'm working with? The second thing to kind of be aware of is implicit bias. They are different, even though they can impact and affect each other. So implicit bias can contribute to the development and maintenance of ableism. Behavior analytics has provided some operational definition around implicit bias and really looking at it being a set of behaviors. A lot of literature will look at implicit bias as kind of more private events, again, that are associated with behaviors that we engage in. So again, this is kind of a growing body of literature in behavior analytics. I do encourage you to look outside the field as well for other peer-reviewed articles, because there's a lot of information about ableism and implicit bias in like kind of a larger quantity outside of ABA. But again, some of the newer, more recently published articles really are aligned with the information that's in other areas. So I'm always going to look at the things that we're talking about, having behaviors attached that we can change as BCBAs. And the first thing to kind of think about is implicit bias specific for us can manifest in many ways. So what it can look like is not using culture identified or preferred language. So I have individuals who come in my office and I always ask them, it's the same thing. Like my doctor's office is like, what do you prefer to be called? And I go by Nikki, right? So I will ask my autistic individuals, what language do you prefer? Right? So the autistic community identifies, identity first language. So autistic individual, autistics. But I have some clients who come in and they prefer to be called a person diagnosed with autism, and I'm going to use that language for that individual. So I ask, but implicit bias might be assuming that I know best, right, and not using preferred language. It might look like avoiding a person who is disabled because we are uncomfortable with them or their disability. It might be denying services because we're not sure how to support somebody, even if we are medically able to do so. I think of a autistic client that I worked with that also had seizures that were well managed and were denied from summer programming because of the seizure. They hadn't had a seizure in years, but it has to be disclosed on the medical forms, right? So is there ableism or implicit bias in regard to refusal of services? Implicit bias can look like believing all disabilities are visible or all individuals have identified their disability. So thinking about, I have a TikTok problem, so take it for what it's worth. I need hobbies, but sometimes videos come up, right? And you see all these like videos where people are filming everybody. And one theme that I've noticed is when people have their placard to park in the parking spaces, and people will say, like, why are you parking here? You don't look disabled. Well, there are a lot of what the advocacy groups call invisible disabilities, right? So somebody who's diagnosed with rheumatoid arthritis technically can qualify to park in the access spots, and they aren't necessarily in a wheelchair, right? So we have this kind of implicit bias of what disability looks like or what autism looks like. And then we engage in behaviors based off of our belief systems. And one thing that I've been running into a lot lately is our assumptions of an autistic person's abilities. So I'll talk with service providers and they will say, well, they're never going to fill in the blank. And my question is, why? Why will they never? Right? Their autistic individuals can grow up and do anything as long as, same thing for me. If I have the skill and ability and support and resources to do something, I will do it, right? So I may not go and be an NBA player because, I don't have the skill. I might be a little short. I'm only 5'5", right? I don't like sports. But I have the ability to do so many things. And because I'm not, presenting as somebody with challenges, and I have ADHD and I struggle a lot with executive functioning, people don't have the same assumptions about me as they may about somebody who presents as what this is society considers more typically like kind of identified autistic. So again, I'm not saying that everybody on this training has all of these thoughts and engaging in all these behaviors, but what I am saying is we, like even me, like doing all this research and training, I still engage in behaviors associated with ableism and implicit bias. And my job is to be able to recognize those and shift my behavior so I am not negatively impacting my clients. And so we'll talk a little bit later about how we can manage this in practice. Okay, so we're going to talk a little bit about the medical model and the social model, because I think it's really important to understand the direction that we are trying to move into. And so I talked a little bit earlier about medical model, but most of the world defines autism by the medical model of disability, right? And so I think it's really important to understand that and also kind of be aware of language and information that comes your way that sounds like the medical model. So when we're talking about that, tell me well, you don't have to tell me, but you can put it in the chat because we read all your comments. But does any of this language sound familiar? Deficits in social interaction, deficits in communication, restricted, repetitive, and stereotype patterns of behavior, right? Like, does that sound familiar? I'll say it sounds familiar to me. I am a mental health provider. I can diagnose autism in my little mental health manual. I don't believe autism should be in my DSM, but that is a conversation for another day. But I'm assuming that we have all heard or used the word deficit, right? And I've used it because I was trained in the medical model. I worked in a medical model field for many, many years, right? Almost 19, 20 years. And I've been licensed in that field for about, 18 or 17 of them. I have used that language. I still struggle with that language. So when we're thinking about the medical model, we're really talking about a framework that is focused on deficits. It includes treating, curing, or normalizing a person's disability or diagnosis. It was originally developed in the field of medicine so that there could be a field, like a framework for treating illness, right? So if somebody is diagnosed with diabetes, like I want to know what their body's not doing so I can support it in doing what it needs to, right? But we're talking about medicine. And I'm not getting into patients' right to choose, but that's kind of where, this medical model came out of. And now it's being applied to almost all kind of intervention human service information, right? So I use them like when I'm talking in my mental health like CAP, a lot of the language for insurance is still deficit based. When I'm talking with my BCBA CAP, right, we're talking about proving to the insurance companies that there are still deficits that we need coverage for. When we start to look at our assessment, measures, when we start to look at especially around like intellectual functioning and all those things, the development of a lot of assessment measures don't take into account that we are measuring from the neuromajority, which means that we are automatically identifying what the neurominority is not doing because we're based off of the neuromajority. And so our outcome measures are based off of deficits that don't align with what the neuromajority identifies. And, I mentioned this before, but, kind of the experience for a lot of autistic individuals where some approaches in the ABA field and other fields as well, so this isn't true just to ABA, is working on, kind of making an autistic individual indistinguishable from their peers. And again, I've used that language in my practice in the past, right? And so it creates this kind of idea of what's called passing. So if you think about a test, like there's a passing score, right? So like, you need to get an 80, and if you don't hit the 80, you're not passing. I experienced it like in school, right? But the idea of passing for the neurominority based off of neuromajority expectations creates significant distress and increases harm. So when we're starting to talk about the medical model, we're really looking at how are we engaging in our services. The medical model for autistic individuals has a lot of implied bias, implicit bias in it, because my bias is that the neuromajority is right. The neurominority needs to be fixed. And then I engage in language and services that way. That is implicit bias. And if you were trained under the medical model, you most likely, and not on purpose, not with bad intent, but maybe engaging in behaviors that align with that. When we foundationally focus only on the medical model, it can contribute significantly to increase in mental health symptoms, increase in challenges engaging in the environment. There's a significant increase in risk of suicide, substance use, and other risk-taking behaviors due to the camouflaging or masking that an individual will learn in order to pass as the neuromajority. And so again, we're just looking at the disparity between, the services we're providing and what possible harm is occurring in between. In response to this, we start to talk about the social model. And if you've gone to any kind of more recent trainings in language and, neurodiversity affirming care, you probably have learned about the social model. And if not, I'm going to explain it to you. So the social model is focusing on the society or the environment learning to adapt and accommodate each individual's needs. So it's the society and the environment learning what they need to do to shift to be inclusive of everybody versus teaching the individual to have to learn behaviors to fit into the neuromajority. It asserts that when we talk about the word disability or deficits, it's really an environmental failure to support the individual versus a failure of the individual to meet society or expectations of the environment. And so this could look like we adapt the person's environment to support each individual. So for example, instead of in school removing somebody because they can't sit in a classroom for the same time as their majority peers, really looking at, is it the fluorescent lights? I have a client that literally cannot handle bright lights. So if we change the lights, everybody can still see and access education and nobody needs to be removed, right? So like thinking about those environmental changes, then we have everybody accessing education instead of an individual being removed because the environment isn't supporting their learning. It focuses on quality of life for the individual versus quality of life for others in the environment. So I'll share this as a personal experience. So I fidget with fidget spinners now. It's mostly my hands. I used to be a leg bouncer. And I can live in a place that sometimes when I move a lot, it can be distracting to others. But I also, that is my need for self-soothing quietly, being told that I cannot do that. And so what I used to do is I used to try and sit really still in school. And I would go home and I would cry every day. Middle school was hard. I would cry every day when I got off the bus in middle school because I was trying so hard to not be disruptive to the people in my class. And that is an example of focusing on the quality of life for others versus for everyone, right? So I, have walked into some really cool classrooms now where there's spaces kids can go, they still can access learning, they manage kind of the distraction by readjusting the environment, and then everybody can stay in and do the things that they need to. Quality of life for all, not quality of life just for the neuromajority. The other piece of this is an education piece. So it's really looking at teaching people in the environment to accept and understand behaviors as communication, as self-soothing, as expression of need, as interest, right? Really thinking about how we're educating people in the environment to understand what may be happening for each individual person. Now, research really shows that, kind of doing early intervention teaching is important. So really starting this messaging, especially in school in like kindergarten, first, second grade, even preschool. And then also, kind of thinking about organizations really taking some initiative to start to train their staff, to start to train their service providers, to train the heads of organizations to understand what the social model really is about and how we can have everybody be more understanding. It leads to more compassionate interactions with others. We have like our more ability to have trauma assumed interactions with others. And I think that this is important to talk about because I'm talking to everybody as BCBAs who are providing services. But if we go back to the statistics where we're looking at 1 in 36 individuals meet criteria for autism or are diagnosed as autistic, I want you to think about, where do you work? How many service providers do you come in contact with in your week? If it's more than 36, the likelihood that you're engaging with collaterals and other peers at work who are autistic, right, or maybe neurodivergent is very likely. And so these skills also help us understand how to provide more neuroaffirming care for our clients, but also to understand that the people that we work with and we come in contact with day to day also may be autistic, also may be diagnosed with ADHD. And if I understand that the environment may not be supporting, or that I'm engaging in thoughts and behaviors that could be ableist or implicit bias, that I can shift my behaviors to be more supportive, even in my working relationships. So I think that there's just like a broad context for all of this information that's really important. We're going to talk a little bit about ethics just briefly, because I think even our ethics code over time has tried to kind of shift with, more information around how we treat the people that we're working with. So in the newest kind of code of ethics in 2020 on page 4, they added in a lot more language around the core principle around treating others with compassion, dignity, and respect. They talk about how we provide services regardless of who walks in our office, that the services should be tailored to each individual so that we are providing compassionate care, but also supporting and maintaining our clients' dignity and having mutual respect back and forth, right? There's already a power dynamic when people walk in our office, right? People are looking for help. And so now I'm in a position of power automatically. And the more that we can do to decrease that power dynamic, the more we're able to have mutual respect, and the more that we will be aware of our own behaviors when we are compromising compassionate care or we're engaging in ableist behavior. Our job is to actively promote a client's self-determination to the best of their abilities. And we'll talk a little bit about choice and assent, in the next section. And it's really important to be aware of our own biases and evaluating our biases. Self-reflection is a really important practice. There is some information in kind of the new behavior analytic literature around the code of ethics, and really, where's like the clarity of the current changes being like substantive enough for us to be engaging in like trauma assumed care, compassionate care, diversity affirming care. Because the ethics code really kind of says like, go evaluate and do the things. And there's an assumption that we are doing those things. And I would say that most of us are. But there's no good kind of like clear delineation of like, what does that look like? Like, what does it look like to identify our own behavior if it is ableist or if I am engaging in implicit bias? What does it look like to determine if I am really assessing the needs of my individual client in addition to stakeholders? There's some information in there. There's a lot of information around competence and, other things of like what you have to do and what it means. But when we're talking about kind of improvements in ethics, there's a lot of conversation around, what else can we put in for BCBAs to have as resources and direction? There is an article by Arango and Listing where they find, they've done some research and they found that behavior analysts are often unaware of or downplay the importance of differences across cultural groups. And so, in their research, they kind of found across the people that they looked at that there was kind of this an unintentional downplay of the differences in culture. And so, how do we start to identify and find information that really talks about like what is culture? Like, what does culture mean? For today's training, like what does it mean when I'm talking about culture, like neurodiversity culture? And do I know and can I identify my own culture and identity, right? So that's really the first step. Do I identify own culture and identity? And then knowing that, how do I identify, what other people may be experiencing, or how do I have conversations with people about their culture and their identity so I can integrate that into treatment? And so there probably is some future implications for, kind of looking at our ethics code, and really, thinking about how we as behavior analysts are doing ongoing practice and learning about our role and our own kind of reflection and how that impacts the clients that we are providing supports to. Okay, so this is the end of lesson 1. Again, I said at the beginning, if you could take anything from this first lesson, I really encourage people to start to connect with neurodiverse affirming communities, to really start to connect with organizations that act as advocates. I always like kind of reflect back when I'm talking and I could hear like an increase in the passion in my voice talking about ableism and implicit bias. And maybe that's because in my last, I feel sad to say this, but in the last couple of years versus like over my whole practice, I really tried to do a lot of development around my own understanding of myself and what behaviors I engage in that are ableist or possibly implicit bias. I do encourage people to, again, like maybe do some research and just understand like what it means. And sometimes these conversations and information can feel very off-putting, like to be like, I support everyone and I do support everyone. Sometimes the way that I support everyone is not what their needs are. And that informs kind of, my own language and experience. And so I really, from summary from this kind of lesson, maybe if people are open to it, really looking at, reading and researching and understanding, how ableism and implicit bias may actually be unintentionally informing, and with good intention, right? We have good intention, but informing our practice and how we can start to shift some of those behaviors. So this is the end of lesson 1. The next step will be there to take the quiz questions. Once you complete the quiz questions, then you'll be able to access the second part of this lesson.